the coronary artery calcium score, such an important screening tool we have in the world. With us today, again, is my colleague, Dr. Brett Nowlan, and he is the director of Preventive Cardiology, Hartford Healthcare Heart and Vascular Institute. Additionally, he's a director of men's cardiovascular health at the Tallwood Urology Kidney Institute. So he's not just a cardiologist and a lipidologist, he's an expert like me in taking care of men. So Dr. Nowlan is with us today. Thank you, Dr. Nowlan, for coming on.
Hey, Tom, great to see you again. It's been too long since you and I have spoken and done one of these, so it's my pleasure to be back with you, man.
Yes. So, and everyone knows that I hammer on those ABCDs in the cardiovascular health, mainly for men on androgens, just every day. A1C is the glucose, B is blood pressure, C is cholesterol, D deposition for the men on androgens, because the deposition with the iron in the polycythemia, that's a whole special thing for men that are on androgens. So, but everything in the end is the heart for me. And it's so important. And we're doing such a terrible job because number one cause of death in America, and I assume the Western world, is heart disease. It's preventable, and a screening tool that's underutilized is the coronary artery calcium score. We're going to focus on this today. Dr. Nowlan, tell us, number one, the data and the history on the calcium score.
Yeah, so Tom, as you know, I'm completely passionate about doing calcium scores because, as you very rightly point out, the tragedy of cardiovascular disease, as far as I'm concerned, is, people having heart attacks. In the United States, 800,000 a year, and about half of those are fatal. And about half of those again, so about 200,000 are fatal within the first hour of having symptoms. So that, the terrifying thing about this is that if you have a heart attack and you end up with heart failure, or if you have a stroke and you're paralyzed, these are awful outcomes. But those are people that are actually already lucky because they've survived, right? And you can go from no warnings to dead in an hour. And so if you look at ways of drilling down to look at someone's risk when they are asymptomatic, the screening tool that we have with the best data behind it is the coronary calcium scan, without question. And this is something that has been around since the 1980s. This is not new technology. This is not fancy technology. This is available to really most people, but it's just very underutilized. And even the major guidelines that we have, certainly in the United States, they mention it, and every iteration of the guidelines, you see it taking maybe a little bit more of a prominence in the recommendations. But the way that I see the data, it should be the prime decider of someone's risk and how you respond to that person with treatment. Maybe nothing, maybe lots of things. But, we use all of these other surrogates for deciding that, like, hey, what's your cholesterol level and what's your blood pressure? And these things have some value, but they're not the best. The best data is with the calcium score. So, the concept in a real nutshell, every risk profile is made up of lots of different things: your genetics, your family history, how much you exercise throughout your life, your cholesterol numbers, blood pressure. Hey, I did some recreational substances for 5 years in college, but I don't do that anymore. I smoked for a little bit, all these things, right? And if you summarize all of those things, what you're interested in, or what you should be interested in, how did all of those things come together and impact your blood vessels? As simply as that. And so if you have a test that can take a snapshot of your blood vessels at this point in time, it's sort of a way of summarizing all of those things and saying, hey, all of those things did not lead to any vascular disease. You have nice protective blood vessels. Don't worry, you're lower risk. Or, hey, you have rip-roaring plaque. whatever went on, you have very vulnerable blood vessels. And the sad thing when people use other markers of risk, and let's use cholesterol numbers. I'm a lipidologist, so I'm very, very interested and passionate in treating cholesterol, but I'm also very interested in treating the right people with cholesterol, right?
If you're watching this video, I'm sure you're concerned for your testosterone levels. In addition to testosterone, you want to check sexual binding globulin, estradiol, free androgen index, and potentially cortisol. That's where I want to talk about today's sponsor, Let's Get Checked. They're a worldwide leader in at-home test kits, so you can get a comprehensive look at your testosterone levels and other labs without even leaving your home. You can order a test kit that will be delivered to you in discreet packaging. Once your sample arrives in the laboratory, confidential results will be available from your secure online account within 2 to 5 business days. These results are reviewed by a clinician, and a member of the Let's Get Checked nursing team may call you to review your results. Let's Get Checked laboratories are CLIA approved and CAP accredited, which are the highest ranking levels of accreditation for labs. So if you want to test your hormone levels without having to leave your home, visit trylgc.com.
So very interested in treating the right people with cholesterol, right? When you use something like cholesterol as the risk predictor, the problem with that is you have a massive overlap of patients with exactly the same cholesterol numbers. This group has no plaque. This group has rip-roaring plaque. And so it's very hard to distinguish those two, and particularly for the individual sitting in front of you in an office or a clinic, right? And so if you take a plaque-based approach, this is sort of how it's referred to, and the first thing that you do is look at the blood vessels. Hey, are the blood vessels healthy or unhealthy? And if they're healthy, don't worry about the cholesterol. If they're unhealthy, worry a lot about the cholesterol and everything else that goes along with risk reduction. So that's sort of the 1,000-yard overview. And what I'm saying here is not opinion. This is data that they've applied. Like, these are all the traditional risk factors that we use. Let's try all of these new technologies and see what adds or what clarifies that risk. And they've done this with many, many different things, be it blood tests, be it imaging tests. And the thing that stands out head and shoulders, but everything else has been the best discriminator of risk, is the calcium scan every single time.
And tell us the science, like, what is it? Is it safe? Is it cheap? What is it? People always say, "Oh, look at my calcium doctor in the labs." No, it's not the lab.
Correct. That's right. So that's an excellent question to clarify that. So a calcium scan is a CAT scan. So it's a CT scan. It is a low energy CT scan. So this is very much like getting a mammogram, not a full blast CT scan. The amount of radiation you're exposed to on a calcium scan is honestly very similar to radon from the soil, just living on planet Earth for about 4 months. So we're not talking about a blast there. You don't get any intravenous lines or injections or special medications or any special prep. I've had my calcium scan done twice, and I went in the clothes that I was in and just lay down, and the scan itself took a minute. Very, very easy. What that scan is looking for is calcium present in the arteries supplying the heart. Quite that simple. And what that calcium is, it's calcified coronary artery disease, or plaque. There's no other reason really to see that calcium. And so if you have a calcium score, and it says that your calcium score is 0, that means you have no calcium present, and there's a lot of very favorable prognosis associated with that. You are very low risk from a cardiac perspective. If you have anything other than 0, 1 or more, that is an abnormal scan. And of course, the more calcium, because it actually generates a number, it's called the Agatston score, and that's how much calcium in total is present in your coronary arteries. So your score can be 20, or can be 400, or can be 6,500. That's the worst score I follow. In fact, someone that you referred, because you astutely picked them up.
Wow.
So that's sort of the range that you get there. And then using that, now using those other numbers we spoke about, what's your cholesterol, what's your blood pressure, what's your family history, we can now be very accurate about calculating a 10-year risk of a heart attack or a stroke or dying.
Okay.
And something I just want to clarify as well. You point out calcium blood test, which is an excellent illustration that people sometimes miss the point of the calcium score. Sometimes people get a calcium score and then they focus on the calcium. Oh, I've got calcium in my arteries, and they sort of look at things like vitamin K2 and D3
Right.
and these things. Not like there's anything wrong with those at all, but the calcium is not the problem. The calcium is the marker of the problem. And that's
Right.
a very important distinction, because what ultimately can rupture and cause an acute heart attack or arrhythmic death or these sorts of things, it's not the calcium, but it might be the soft plaque that's sort of 1 centimeter downstream that you can't see, but it's there based upon the positive calcium score.
So let's just hit that real quick. So many people, and even good doctors will launch an argument. Hey, the calcium score it's the soft plaque we're looking at. So distinguish, and I always say where there's smoke, there's fire. So where you have 0, you're not out of the woods yet. Let's take care of your risk, and then let's check it, because I've seen so many guys go from 0 to 10 or 40 or even higher in the course of a few years. And they say, oh my God, doc, what happened? You didn't take care of your risk factors in between. Right. The cholesterol, the blood pressure, the cholesterol, all these things, the glycemic index, the smoking, all these, being overweight, sleep apnea. So,
correct.
But let's talk about the soft plaque versus the hard plaque.
Correct. So that's also a great thing to distinguish, because sometimes people won't like the idea of their calcium scan being positive. And to be honest, mostly people are trying to look for confirmation bias that they're okay, to be perfectly honest. And, one can understand that. When you look at the data sets that have looked at the calcium score versus outcome, that's really where it has its value, right? The prognosis associated with it. They haven't tried to parse out the calcium score based on, well, how dense is it, or is it in this vessel versus that, although there is some work there, or is it scattered, or is it just 5, or the rate of progression. They've actually taken just simply the score and followed those people to see how they do. So what that means is all of these subtypes or associations between the calcified plaque and the soft plaque, or calcified scattered plaque, or dense plaque, all of those things were captured in the risk prediction. So we don't need to try and be too clever about where the calcium is, or if it's scattered, etc. The score associates very strongly with risk. And I think that's really the best take-home message is, don't try and smear away the significance of a calcium score if you have it, by looking for this data that says, well, it's just clustered in one spot, that's probably better,
People
or
do
high
it.
density. Right.
Doctors.
Yeah, you're right. And sometimes it's a lack of understanding of the data where you can look at one data point and say, well, this seems to suggest that scattered plaque is a little bit worse. So if mine's all clustered, maybe that's better. But, again, I think not losing sight of the basics and the most important. And I tell patients this all the time. When they get a calcium score that's positive, the most important data you get from that calcium score is your score is not 0. That's sort of level 1 of that data. Hey, guess what? You have coronary calcium. You have plaque. That's the simplest and most important sort of result you get from a calcium score. Or, of course, you have a 0. And then we go into the details when I talk to my patients. This is the actual number. This is how it compares to your peers. This is the prognosis associated, and this is what we do about it. But really, the most data and the most information you get from a calcium scan is there no plaque? Is there plaque? And take it from there.
So I'll tell you what, next very important question that people are going to ask me, who needs it? Let's talk about the age based on the data. Is it 30 or 40? I saw some new stuff on that. That it's not actually accurate unless they're 40. But then I saw American College Cardiology, American Heart Association over the years has said, if you're intermediate risk, 30, 35. Okay, so who needs the calcium score?
So my answer is if you have a heartbeat, you need a calcium score.
Okay,
Now,
what age? What age?
now, let me just qualify that, because I think it's an underused test, and there is some very, very interesting data out there. There was a study called the Coronary Artery Calcium Consortium where they calcium scanned 20 to 30-year-olds. Okay. The incidence of having a calcium score other than 0, so 1 or more, in the 20 to 30-year-olds was 13%.
Come on.
1 in 8. So you look at data like that and you go, wow. Now, these weren't particularly special people with, florid genetic disorders or anything like this. This was 20 to 30-year-olds. So if you look at the guidelines, and the guidelines are trying to capture good recommendation for the population as a whole. So you always have to realize what the guidelines are doing. It's not for the individual in front of you, it's for the population.
Big picture. Right.
Correct. So the guidelines say the best use, the lowest hanging fruit use of the calcium scan is if you are intermediate risk based on other risk prediction systems, right? And also if you're unsure about whether to treat someone or whether they are high risk, low risk. That's the best use of it. Now, does that mean it should be the only use of it? No, I'm a very strong advocate that you never get data from a calcium scan, as far as I'm concerned, that is wasted data. You either will get a scan that confirms what you knew about someone's risk, or you will be surprised.
Yeah.
And either of those is valuable, right?
Yes, I see it.
So, so you and I have seen people like this all the time, Tom, where you have a young, fit, healthy, apparently healthy guy, asymptomatic, and you do a calcium scan, and he's in his mid-30s, and he has a calcium score of 150.
I see
That's
it.
mind blowing, right?
Yeah.
You see it all the time. And I see it on the other end of the spectrum. You see someone that has a very lousy looking biochemistry, bad cholesterol numbers and triglyceride numbers and blood pressure, and they've smoked, and you're like, oh, the calcium scan here is just a formality, and it's a 0.
I can't believe it.
Right. And I love those cases because it just shows how fascinating we understand the biochemistry, the cholesterol, correct. We understand the biochemistry of atherosclerosis very well. What we understand much less well is the endothelium, the blood lining of the blood vessels, right? And the endothelium is a complicated structure. It has this floating glycocalyx, and then it has these endothelial cells, and then it has a proteoglycan layer, all these things that can protect you or can make you vulnerable. And so you need to evaluate the interplay between those two things, the biochemistry and the endothelium, to understand someone's risk. And a lot of guidelines and recommendations talk a lot about the biochemistry and nothing about the endothelium. And wow. So again, I say this kind of facetiously, but not really actually, that if you have a heartbeat, you can benefit from a calcium score. But again, the best use is if you're intermediate risk.
Okay.
And typically it's recommended, hey, start at age 40 if you're just generally screening someone, or if you have a very bad family history. Let's just say your dad had a heart attack at 45.
Right.
Scan yourself 10 years earlier than that event.
So like the colonoscopy for family history from the American College of Gastroenterology. If you have a family history of colon cancer, you look at that, you look at that person, that focus, and then everyone else who is a primary relative 10 years before or earlier.
Same concept, exactly. And but again, so those are good frameworks. But for example, I see people like this in clinic all the time where they have some risk factors and they're very concerned or nervous, and rightly so, because they feel like they're walking around with an unknown landmine in their chest, right? You can help that person by calcium scanning them. And if it's a 0, you can say your 10-year risk is about 0.8%.
Wow.
Right? So your yearly risk is less than 1/10 of 1%.
So that's really more, that's that calcium score, hard plaque versus a soft plaque. Hey, you never know, soft plaque could be there. That's the number right there.
Right. And again, the devil's always in the details with this kind of scoring. So sometimes the concern with doing calcium scans on younger people is that you may have soft, uncalcified plaque, and then you may miss it. Okay, so that certainly is possible. One thing that you can rely upon with the calcium scan is if you do a scan and your score is 0, your at least 5-year risk is very, very good. Now, all risk predictors, including the calcium scan risk predictors, are not very good at predicting lifetime risk. And that's because you have actually followed people for 12 years, 10 years, and derived risk, but they haven't really followed people for a lifetime and said your lifetime risk. So when I scan someone and it is a 0 and they have risk factors, typically what I say to people is, you probably should repeat this at 5 years so that
Right.
plaque is not going to sneak up on you. And you shouldn't take a 0 as red and now you're done for the rest of your life.
Right.
You can feel reassured that you're low risk right now and keep working on these lifestyle things that can maintain your health, regular exercise, healthy diets,
Right.
healthy sleep, all of these things. But don't ignore this and maybe repeat this in 5 years' time, something like this.
And the feature for me and my guys who are watching out there is that men have early heart disease versus women. It's multifactorial. And then if you're on androgens, gentlemen, if you're on androgens, it's controversial now, which is actually something I think kind of great and interesting, because it seems like the mainstream traditional medical community is giving more of a blessing to testosterone, at least in America. And that's interesting because we have no new data, but they're reinterpreting it and saying, hey, maybe it's not so bad for the heart. Hold on. It may have nothing to do with testosterone. What are your risks? So are you putting your risks on steroids or androgen, and that with the red blood cells, the blood pressure, and all these independent? So it's complicated. So for my gentlemen out there, again, around 30, 35, if you have a family history, that's a no-brainer. It doesn't hurt you. It's cheap. It's about $100 or more or less. It's not a CT angio. It's not a CT. The doctors, people don't know who it is. They don't know what it is. They say CT angio. No, your insurance won't pay for it. It's not a CT angio with all the radiation, IV contrast dye. It's a simple 1-minute quick scan of the chest. It's a chest CT, but they have a Gansom unit. They have a special protocol. It's super easy. It's looking for calcified plaque. All right, let's wrap up with this. Tell me your interpretation of the scores. And this is going to be, it's a beautiful video. I want to keep it succinct though. Your interpretation of the score give us some 3 examples. Low, 0, 0, 0, 0, talk about that. Then we have low, medium, high.
You got it. So when you get back that score, the Gadsden score, the only normal score is 0. 0 is truly different from 1 or more in terms of risk. They've demonstrated that if you move from a 0 to a 1, you're about double your risk just with that move. And then risk goes up from there. But if you're a 0, you can feel reassured that the associated prognosis with that is very, very good. And your 10-year risk of an event, is probably lives somewhere between 0.5% and 1.5%, something like that. So if that is your 10-year risk, then you can figure out that the risk reduction that you may derive from medications, for example, is not 0, but it's much, much smaller. You often hear this idea of, we could halve your risk by aggressively treating your cholesterol. And that's true, but if you're halving risk that is initially 1%, now you're treating someone for 10 years to get a 0.5% reduction in risk, which is small. Now in my clinic, I don't make the decision. I present that data to patients and say, does this sound like it is worth it to you? And
what's your appetite? I say, what's your appetite?
Correct. Same concept, right? And some people have the appetite to do maximal risk reduction. I'm saying, fine, you understand the data. Let's do that. And some people say, I think I'm good. I'm very low risk. Both of those are very, very reasonable. But of course, I help the patient make that decision for themselves. Great. If you move from a calcium scan of 0 to 1, there's a difference there, and that is my personal Rubicon to recommend adding medications onto lifestyle modification for risk reduction. And this is another very important concept. People substitute exercise and diet as a way of reducing a risk. They substitute that for medications. And these are completely different modalities of risk reduction. So you, as the patient, can choose exactly what you engage in, right? Be it lifestyle factors or be it medication, but they should not be thought of as an either or. These are different facets for modifying risk. And the higher the risk, based on the higher calcium score, probably implies that you're going to get more benefit from doing more stuff.
Synergy. You
and
want
s-
synergy.
Right. And so you want to pick the people that you throw the kitchen sink at and throw the kitchen sink, because that guy's at a higher risk of dying or having a heart attack or a stroke. Right. So if you look at calcium scores, it's also very important to look at the calcium score in the context of someone's age, for example. So there's a way of adjusting the calcium score and comparing a calcium score to someone's peers of the same age.
Right.
And
Right.
gender and race, in fact. And so you can say that if you have a calcium score of 10, but you're a 40-year-old, that has a very different implication from a calcium score when you're 90 and it's
Right.
10.
Right.
It's age adjusted, right? So another broad rule is it seems like there's very clear benefit. If your calcium score is 1 or more and you are 55 years of age and older, very clear benefit there to adding medications onto lifestyle factors.
Okay.
But the thing is, it's all a matter of being better about risk prediction and then being able to understand the data to see what you're applying for someone.
And what I love to do is, again, it's to present to the patient. I say it's not McDonald's medicine with great doctors and nurse practitioners. It's one-on-one, but there's such a limitation of time. So
Right.
you want to understand the endothelial, the risk. Then do you really want to stay free of disease? Well, exercise and diet, no question. But I love the synergy of the medicines of the the glycemic medicines. That's with the diet and exercise, and metformin, and there's some other new medicines we could talk about later. And then blood pressure medicines and cholesterol, of course. And when you do find this synergy in the right medicine, when you have a great doctor, you not only do you not feel better, but your sex is better, because there's the nitric oxide in the, because your
Right.
penis and your corpus cavernosum is driven on nitric oxide endothelially. And this is, come on, gentlemen. So don't put the head in the sand, and this brings men out. So, all right, this is amazing. So much information. I want everyone to watch it. So I want to keep it right here. Dr. Nowlan, how do people contact you, please?
Yeah, so Tom, my practice is in Bloomfield in Connecticut in the United States. I'm part of a practice that's now under the banner of Hartford Healthcare, and my practice is called College of Cardiology at Hartford Healthcare. That's where I spend most of my time practicing. So certainly people can reach out that way. And we have a lot of great practitioners that I think also have an understanding of this. Certainly in my office, and then sort of further afield in Hartford Healthcare as well. And you have certainly referred a lot of people to me, and people who have seen these videos and have sort of realized the importance of this. I think these videos really have made a very big difference to a lot of people, because this is information, again, just sort of circling back to how we started. This is old information. It's nothing new about this. In fact, the more information they gather, the more valuable it seems, and it's not being grabbed a hold of by the medical establishment as a whole as it should be. And so if people can be advocates for themselves and ask for this test from their doctor and say, hey, this is important, can I have this? I'm going to pay for it. I want to understand my risk. This is how we can change it from the other end of the spectrum, right?
Right. So, gentlemen, if you're even in your late 20s, even mid 20s, be aware of this. Maybe you don't need it. And then around 30 to 40 sometime, you really want to utilize this in your armamentarium for screening, and then understand. And then, of course, I have the Anabolic Doc app where people come and they learn all this information, even access to me in Zoom meetings, which I have to get ready for. But Dr. Nowlan, thank you so much, brother. This is,
Tom,
I think,
thank you.
We're going to move on. The future, one of the next things we'll do, guys, is we're going to do medications for how to treat heart disease with Dr. Nowlan. We'll do that next, guys. So stick with it. And thank you so much, everyone, for watching. I really hope this helps everyone.